Very good afternoon to all. So next 10 minutes I will be talking on the RET gene alterations. So before moving on to the RET gene alteration, let's see what are the recommendations about RET gene fusion or alterations. So if we see the recently published ESMO working group recommendations for NGS, RET fusion is included as a SCAT score 1A like any other EGFR, ALK or ROS alteration. What about the Asian guidelines? In Asian guidelines, it is said that we have to test for PDL1 and perform multi-gene panel testing for actionable genes. If it is not feasible, then at least EGFR, ALK, ROS and PDL1. And when they are negative, we have to go for multi-gene panel testing. There has been a expert consensus which is published specifically for RET fusion testing, in which it is strongly recommended to do RET fusion testing in all stage 3, stage 4 NSCLC, along with other driver genes. And also if just other driver genes are performed and they are negative, then also you have to go ahead with multi-gene panel testing for RET fusion gene. So if we see, it is exon 20, this gene has exon 20, and most of the mutations, they are clustered in the cysteine-rich domain and in the tyrosine-rich domain. And when you see the gene rearrangement, it is mainly in the intronic 11 region. Mostly two main tumors, thyroid tumors and lung carcinoma, have this RET gene alterations. Mutations mostly in medullary thyroid carcinomas and fusions in papillary thyroid and non-small cell lung adenocarcinomas. So what happens in RET fusion? There is a gene rearrangement which generates a fusion gene consisting of juxtaposition of C-terminal of RET protein with N-terminal of any other protein. And this leads to a chimeric protein with downstream signaling pathway activation with PI3K, JAK-STAT and MAPK pathway. So most common RET fusion partner is kinesin family KIF5B, and there are other common partners as well. Epidemiologically, if we see, all are like young non-smoker females with a solid variant being the most common in lung adenocarcinomas. So it is seen across various other solid tumors, including salivary gland carcinomas, unknown primary is colorectal, but mostly seen in thyroid and lung adenocarcinomas. In thyroid, in papillary, it is as high as 8 to 9%, and in lung adeno, 1 to 2%. After it's first reported in lung cancer, it was later approved RET TKI in 2020. So coming to the biomarker testing platform, as we see the incidence is very low as 1 to 2%. So all the more we need to know about the testing nuances. So either we detect it at DNA level, RNA level or the protein level. At DNA level you can use FISH or NGS. At RNA again fusions are detected. And in protein you see expression, IHC expression. So RET IHC, it is very easy to implement any IHC. Results you will get in 1 to 2 days. But what happens with RET IHC is that, in general, if you see the literature, there is unreliability of the current IHC testing, though we have monoclonal antibodies available. So the false negative and false positive rate is as high as 40%. And that is because of very low level of expression of protein, which is expressed after this fusion. So definitely IHC cannot be relied upon for detection of fusion. So that is a big no. So what happens in FISH is that in general for any fusion, FISH is considered as the gold standard, and it is a highly sensitive technique and can be applied even to very scanty tumor, even when the tumor cells are just 50 cells maybe. But it needs technical expertise, and what we can miss on FISH is complex gene rearrangement. So if we see what is the hindrance with FISH, because for ALK and ROS we know FISH is a very good technique. What happens with RET is that all the fusion partners are in very close proximity to each other. All this, mostly 90% of the cases we have these two, and they are very close to the RET gene. So what happens is that when you look at the breakpoint, if the partners are very close, you cannot appreciate this split. This will be very close. So this can be mistaken as FISH negative. So that is why FISH is not a good technique for RET fusions. Also, there is some prognostic implications with the fusion partners. In fish, you just know that whether the RET gene is rearranged or not. You will not get to know what are the fusion partners. So there is some literature on good prognosis with CCD6 RET fusion partner and worse with the other one. So fish has this drawback, and that is why also it is not applied in diagnostic setting. So coming to real-time PCR, as with any other PCR, it is a highly sensitive technique, but we know there are as high as 45 to 50 fusion partners with RET, and it is very difficult in normal settings to detect 1% alteration with multiplexing with 50 genes. So you will tend to miss the novel partners and will get false negative. So then what is the answer for RET fusion is NGS. So NGS, there are always very queries in whether we have to go for DNA-based NGS or RNA-based NGS. So in NGS, you will detect all the gene alterations, DNA gene like SNVs, CNVs, fusions, all in one go. But again, it depends which level you are analyzing. So what happens in DNA-based testing? So when you extract DNA, and do fusion testing on it, you will also get to know DNA variants along with it. But the panel should have extensive intronic region coverage. Only then you will pick up fusion at the DNA level. For example, if you have intron 11 as the most common, but some cases you might have intronic 7 as the breakpoint. So if your panel is not including intron 7, you will miss this and you will get as a ROS negative. So what is the single most solution for this is a RNA-based fusion testing. Again, what is the methodology of library preparation, whether it is hybrid capture or amplicon. So I will just spend 1 minute on this. So when you say hybrid capture, it means the region of interest, you have oligonucleotide probe, which will capture the region of interest, and then you will do sequencing. When you are doing amplicon based, you need to know which is the right and the left side partner in fusion, and then you will plan PCR primers. So if there is a novel partner, it is not in your panel, again you will miss. So that is the disadvantage of having a amplicon based sequencing chemistry. So when it comes to testing methodology, you say IHC potential local implementation, any local lab can start, but because of the significant false negative positive rate, it is not recommended. Neither is fish recommended because of a significant false negative rate. So in DNA NGS and RNA NGS, so NGS is the method of choice. So when you compare DNA with RNA, RNA is the most recommended. So that is what is said in NCCN guidelines. So NGS is highly specific, but RNA based NGS has to be preferred. So just few minutes on the data at TMH. So 2021 to 2023, around 1800 cases of NGS, of which this is about lung. About interpretable were 1750, and if you see, only these tumors showed. So in lung, out of 1750 cases, only 12 had RET fusion. So it is around 0.7%. It is same as that seen in literature. Most common is this KIF5B, 75%, and 25% coil-to-coil domain fusion partner. In thyroid, out of 350 head and neck tumors, 67 were thyroid. Out of which, out of 20 medullary carcinomas, RET mutations were seen in 10 cases. Papillary were 15 and RET fusions were seen in 3 cases. So, and these were all the typical fusion partners. Do I have time? I will just like to discuss one case here if I have time. So this is a very interesting case recently we are having. So 46-year-old male operated case in 1999 of a papillary thyroid carcinoma who received 5 cycles of RAI that time in 2003 and then was on a follow-up. In 2022, PET-CT showed lung metastasis. However, patient was asymptomatic, so no treatment was started. Subsequently, in August 2023, on PET-CT, there was pleural effusion, pleural thickening, and pleural cytology showed metastatic papillary thyroid carcinoma, and now the patient was started on lenvatinib. And then with a 9 months of DFI, there was a significant, partial response, and then there was a progressive disease, and now the lung nodules were around 3.5, 2.4, and it was increasing in size. So for NGS, actually, lung biopsy was done, and if you see in this lung tumor, there is nothing like a papillary thyroid here. It was a very solid tumor with necrosis. And to our surprise, the immunoprofile was of a lung adenocarcinoma. It was not thyroid, it was not Paxet, it was Paxet negative, just TTF1 napsin positive. So it was a lung adenocarcinoma. So how many of you are ready to buy this in a typical clinical scenario of metastatic thyroid? This can be a primary lung. Is it possible? Yes. So NGS showed again this NCOA4 RET fusion. And along with this, TERT promoter mutation and P53 mutations. So now this RET fusion can be seen in both lung as well as thyroid, but this, if this was a single gene testing, you will miss the rest of the alterations. So when you see this TERT promoter P53 along with any other fusion, it is most of the times it is a thyroid primary. Now the problem here was that it was looking like a lung adeno on histopath. It was very different from a papillary morphology. So there was this paper published recently in which they compiled that what is the profile of RET fusion lung adenocarcinoma. So as you can see, like it is mutually exclusive with any other commonly seen alteration in lung. So all EGFR P53 are here in RET negative, whereas rest of the non-significant ones are usually seen with RET fusion positive if it is a lung adenocarcinoma. And if you see thyroid tumors, so usually in thyroid, in RET fusion positive, you will see P53 TERT promoter mutation. So no matter how it is seen, it is still a metastatic thyroid carcinoma. But meanwhile, because the clinician wanted to know whether it is a lung or a thyroid, to add chemotherapy or not. Another thing, this patient had a PDL1 of 80%. Now usually in RET fusion positive lung adeno, PDL1 is negative. Vis-a-vis in thyroid, it is high. So most of the things were against a lung adeno, but histology was very classical of a lung adeno. So meanwhile, again we got a repeat biopsy. Now this was the same patient, pleural biopsy. It was entirely sarcomatoid tumor, but just one core showed a papillary pattern. So this was just 1 to 2% of the core showing papillary pattern, and this was given as a metastatic thyroid. So point here is histology very varied, and it was looking very high grade. So again, here it was Paxet TTF1 positive, and just for academic purpose, NGS was repeated here. We saw the same fusion partner here with a very high read count. So when you interpret molecular results, we have to be aware of pros and cons, and nuances should be pertaining to an individual genomic alteration and the platform in a given clinical scenario. Here, the biopsy was just done for the NGS testing, and not to confirm whether primary or metastatic. So to summarize, IHC is not recommended. Even FISH being sensitive is not recommended for RET fusion testing. DNA NGS can be performed, but RNA NGS is the preferable. Thank you.